Hi, Dr. Gharagozlou here with Healthy Sleep Care. Today, we are going to discuss the treatment of cases of chronic restless leg syndrome. Um, have you heard of these people who cannot stay in one place, who have urge to move? They feel their have to move and cannot stay. They get very uncomfortable if they are in the movies, if they are in the car rides, or airplane is going to be hell for them. Well, in the last video, I talked about management of intermittent cases that are not too bad and infrequent and intermittent, but some of these cases are pretty severe. They need most of the days to take medicine, otherwise they will become miserable. In general, if we have symptoms that interferes with our sleep or function more than twice a week, that is considered to be persistent and chronic restless leg syndrome. In the previous videos, we discussed about differential diagnosis, what other conditions can do this, and what can we do if we have a mild case. But today, we want to talk about more chronic cases and severe cases. So obviously, you have to do all of the lifestyle changes and iron replacement that we have discussed in the past. For instance, if you have insufficient sleep, if you have other sleep symptoms or diagnosis, if you have circadian cycle issues, if you are using too much caffeine or too much alcohol, you have to address that. You have to make sure the iron for the patient or for yourself is up and is not low in the blood. That would be not a good indicator of the brain iron, but a rough measure that we have and we can just do easily with the blood work. So now if you have done all of this and the patient has so much symptoms and between you and the patient, the decision is made to do something pharmacologic-wise for the patient, then the first drug choice is some drugs that are called alpha-2 delta ligands. These drugs start with gabapentin. It's a really frequently used drugs for pain, neurologic pains, even back pain. Sometimes psychiatrists use it for their own reasons, mood stabilization. Gabapentin can be started around 300 milligram, but the patient needs multiple administration of that medicine. And for RLS, based on the timing of the symptoms, we can use maybe 2 p.m. and 7 p.m. and 11 p.m. Another medication is called gabapentin enacarbil or Horizon. This medicine is a prodrug to gabapentin and has a little bit different way of metabolization inside the body. So one administration of that medicine is enough, and of course we can adjust the dose. Both of these medications are more dangerous in elderly, so we have to decrease the dose in elderly and be careful. Another medication in this group is Lyrica or pregabalin, that we can start with around 75 milligram and go up to 300-400 milligrams. All of this group can cause drowsiness, sleepiness, dizziness, feeling unsteady, and also can cause cognitive symptoms like forgetfulness or brain fog and things like that. Luckily, most of these symptoms are transient and can go away. For this group of the patients, if we increase the medicine a couple of times and we cannot get anywhere, we have another choice. And that choice is dopamine agonist. The dopamine agonists that are appropriate for RLS patients are Mirapex, Requip, and Nupropatch. Mirapex and Recuib are pills, and Recuib has an extended release pill. The problem with this group of medication, in parentheses, this group used to be the first choice, but because of the problems that they have now, we are turning away from that. Them are they can cause a phenomenon called augmentation. That means the symptoms get worse, come earlier, and also can come to the arms or spine that feels even worse. Normally on this group of dopamine agonists, we can expect a pretty good chance that augmentation happen, but it happens around 7 to 10% per year and around 40 to 70% after 10 years of use. So for many years, the patient can use them and get benefit from them. If we are thinking about augmentation, we can increase the dose a little bit, and we can even increase the dose twice. We can split the dose. We can use extended release formulas. But if we are getting nowhere, we have to change the group. Like I said, an addition of something like Sinemet even can be tried, even though personally I'm not such a big fan of that medicine for RLS. The dopamine agonist, like I said, Mirapex, Recuib, and Nipro have side effect of nausea, drowsiness. They can cause falls, and the falls in the night in an elderly patient can be pretty troublesome. Also, they can cause cognitive issues. Another very important problem with these dopamine agonists are impulse control issues. So if the patient has history of gambling, history of excessive shopping, and also hypersexuality, this would be a red flag not to use this group of medication. These could happen around 10% of the time, and also they are dose dependent. So on higher doses, we have to especially watch for these side effects. We have to discuss prior to prescribing medicine, and every time we have to ask if this kind of side effects are happening. So if they happen, it's best to move on to another group. Again, don't forget about the iron level of the patient. Then we come to the group of the patient that we are running out of options. They have pretty severe symptoms. Their symptoms are now both in arms and legs, and they're very miserable. And most of these patients have more than 12-hour symptoms. And the question is what to do with them. Opioids is a very good way to go. If you go to consensus letter or consensus statement from Dr. Ellie and Dr. Silber, and I like to mention my own mentor, Dr. Walters, who is a major pioneer of RLS. The data and the consensus of the scientists of this disease show that opioids are an excellent treatment for refractory cases, and they are not misused, and dose escalation and misuse among the correctly selected patient of RLS is pretty low. So everybody comes out of your door, they're not a good candidate for RLS treatment with opioid. However, this is a very good choice for a patient who has gone through the steps and had augmentation and have contraindication for other treatment. Obviously, opioids are opioids. We have a pandemic, an epidemic of opioid. People are dying left and right. So you don't want to just prescribe opioid out at this point. But in the right patient, it's really helping. The side effect of opioid is constipation, nausea, sleepiness, and also they can cause central sleep apnea, and they can make the obstructive sleep apnea worse. So we want to be cognizant about those kind of issues. Nausea and constipation can be treated symptomatically, and also opioids can cause itching. This is not because of allergy, this is because of histamine degranulation. And in an appropriate patient, we can consider adding antihistamine, but we always have to weigh the risk and benefit, and also antihistamine sometimes can make the RLS worse, so we have to think about that part as well. Choice of opioid is doctor preference. Oxycodone has been used, hydrocodone has been used, methadone has been used, and there is appropriate dosing that your doctor is aware of it. If opioids are going to be used, at least in USA, we have to have frequent urine tests to make sure that the patient is actually taking the medication, and also nothing else shows up in the urine. You have to have pain contracts with this patient or opioid contract with this patient. So they have to get it from a single doctor and a single pharmacy. You have to check the cures database to make sure there isn't another prescriber giving the patient something that would not be appropriate or has unexpected interactions. If you look, if you look at the literature, there are some interesting other modalities mentioned. I just had a patient who every time in the airplane had RLS symptoms, and he mentioned that he used the pneumatic, not pneumatic, he used the regular compression socks with great response. There are some anecdotal and small studies that show that pneumatic compression devices might work to some extent or as additional therapy. There are some studies, small, but mention the use of the spinal stimulators, especially the transdermal stimulators, not from inside. It's like a TENS unit that gives impulses of electricity that might help with the restless leg symptoms. I did have patients who use TENS for lumbago, and then they reported that it seems my RLS symptoms are also better. So there is definitely anecdotal evidence for that and smaller studies. Cannabis, not a good idea. I have another whole video about cannabis and how it is not good for insomnia. However, here there is some anecdotal data and very, very small, not clinical trials, but case series and case reports that it might help, but we don't know how much and what is the dosage and how to get that dose to the patient. And of course, the products are in the market are not just THC or not just CBD. There are so many things in it. And another problem is cannabis will interact with other medications of the patient, and there is concern that it increases the side effect of the other medications that the patient use, including the patient medication for restless leg syndrome. So it's not recommended. In old literature, carbamazepine has been mentioned for RLS. So in peculiar clinical situations, a doctor might decide to give it a try. It's obviously not something that we always do. Vitamin C and vitamin E in certain patients, renal patients, might help for the symptoms. It is worth mentioning renal patients have a lot more restless leg symptoms because of their uremia. And also there is no evidence that magnesium works. So some people swear on magnesium. I had multiple patients who swear on magnesium. It's something that doesn't have a lot of side effect. Magnesium oxide and some other salts of magnesium can cause a lot of diarrhea. And when it crosses blood-brain barrier and fast, Some salts of magnesium can give you intense dreaming, including intense nightmares. But you have to see if it works for you. If it works, it's probably for nocturnal leg cramps and not the RLS itself. But we want the patient to have a better experience, so a doctor can decide to give it a try. And the next video that I will publish on RLS series in a week or two, we will discuss specific population, like renal population, pregnant patient, children, and so on and so forth. So thank you so much for watching, and please give us a like or subscribe or somehow support us. Thank you.